Welcome back to the Papers Podcast. I have here with me today Jason. How are you, Jason?
Hi, everybody. I'm feisty. I'm ready to go. Let's make a spicy episode.
And Lara.
Hi, everybody.
And John, you have something interesting for us today. I got to say, I first heard about this paper a day after it came out when a group of pharmacists in Taiwan wanted my opinion on it. They thought it was the best thing since sliced dumplings.
Thanks, Linda. No pressure. Dear pharmacy community across the world, I hope we can live up to the expectations or the needs that you might be laying on us. To be honest, I heard about this as well. When it came across X, a number of people messaged me, and when it hit the social or the headlines, whatever those look like today, I heard a lot about it. The paper we're actually talking is a paper by Gray et al. The title, it's a bit of a mouthful, but it describes everything we're going to talk about. The Association of Internal Medicine Residency Milestone Ratings and Certification Exam Scores with Patient Outcomes. Published in Jama, hot off the press in the first part of May of this year. Buckle up. I think this is going to be controversial. And I want to put my arms around a big number of literatures, which I think are all relevant to here. The first is that we've said it many times, that the line of causality in education is a tenuous at best a link, meaning you can't expect a classroom event to lead to a direct patient outcome one-to-one because there's so many dependent variables that happen along the way. There are a whole program of research, and I'm looking at you, Daniel Schumacher, of researchers and scholars that are trying to find resident, or I guess by association, clinician sensitive markers that we can actually measure, that if we have some kind of educational intervention, will that then lead to some kind of change in patient outcome? And so there's work there. But there is another side of the house of medicine that's asking louder and louder, show us the evidence that this works. Because for the last decade or so, at least in North America, and certainly it's a global phenomenon, we've seen a change in our approaches specifically to graduate medical education or postgraduate medical education, whatever the terminology is in your neck of the woods, but also reaching out into undergraduate medical education as well, and into the other health professions, this idea of competence. And so the line that comes from one side of the clinical world is, okay, we've diverted dollars from patients and other research priorities into education, show us that it works. And they want a very engineer-like, very pipeline type of phenomenon, and I would argue very rigid and fragile type of argument that says all of this efforts has impacted in a direct one-to-one correlational way the quality of patient care being delivered. Now, on a previous podcast that doesn't exist anymore, the Keyline podcast, we reviewed some papers by Ash and by Chen, and they looked at, through their own programs of research, the impact of a training program, not at the level of the individual, but they said your educational geography was your destiny. Put another way is you really get imprinted as a young health profession in the community where you train, so that decades, 1, 2, even 3 decades out, your patient outcomes can be correlated to the practice environment in which you train. Now, there's a third literature, and I hope that on this jog this morning on a Tuesday or in your commute, you can hold all these pieces in your working memory together that I want to point out. That there is a great association between knowledge exams predicting future performance. We see it in a wide body of literature in the undergraduate studies literature outside of health professions or health sciences that says how you do on your entrance to university placement exams predicts future performance. Part of the critique there is that's just predicting your ability to take tests. And when you look at these university placement tests, particularly in the US, there's lots of critique around the socio-cultural dynamics there about, are we measuring intelligence? Are we measuring future performance? Or are we just measuring a social dynamic about how you can take a test? Within the House of Medicine specifically, Robin Temlin, who heralds from Melinda's home team, has looked at that prediction of knowledge tests on future clinical practice in medicine, showing that how you do on exit from residency training programs and how you will do in practice on clinical management shows a strong relationship. So the movement to competency-based education says, let's get past simple measures of knowledge and start assessments that look at all of the skills and competencies necessary for successful practice, whether it's around communication, whether it's around collaboration, around advocacy. And let's look at authentic measures that show how you actually perform, not on a computer station, not with a pencil in your hand, but actually on the ward, in the OR, in the clinic. So with all of that, there is lots of controversy. Where do you sit? Linda, Lara, Jason, there's a singular line, we're going to show that this works, or is the conversation more nuanced, and where do you fall within that nuance?
So it's very nuanced. And most of the problem, as I see it, is what you pointed out briefly. It's a domino effect. There are multiple steps in whatever it is someone learns. They may learn about, a student may learn about beta blockers, for instance, in pharmacology, but there are multiple steps before that knowledge gets into practice. The resident and senior student may actually prescribe those medications under the supervision of their teacher, but also in a certain context. They then use what they've learned in practice. But one of the problems is the influence on patient outcomes by the system and the context that people work in is huge. It's much bigger than did you learn about a beta blocker 15 years ago. And some of the older literature that you didn't mention, yet another thing to get your hands around, is the CPD or CME literature, which looks at how much the system influences what individuals do in their practice. The other thing I think we have to recognize is that this is a moving target. It's not something where you learn something at time A, whether it be a knowledge or a competency, and then use it at time B later. Medicine progresses. We didn't have mammograms way back when. Mammograms came into play. The outcome was that the outcomes for breast cancer got better. But was that because of learning or because of adoption of technology or innovation? I don't know. Finally, do you look backwards or do you look forward? Do you start with an outcome and then look back at how people trained or what they learned, or do you look forward at, say, milestones or tests and then how they do in practice? So, as I say, it's not only nuanced, but it's complicated.
So for me, John, this issue is one that I take real issue with, and it's something that I feel very passionately about. So I'm going to try to be really short, but I know I have a tendency to sort of go when I get cheesed, and this cheeses me off because it's such the wrong question. This is these kinds of questions about can education impact patient outcomes it's a hangover. It's like the worst hangover from a positivist, post-positivist way of thinking about life. There has to be a right answer. Somebody has to be ranked higher than somebody else. There must be measures. And it's not the right way of, in my opinion, I think thinking about it in those terms is not beneficial. I think thinking about it in those terms starts to appeal to really dangerous consequences. If we really buy into this, now let's start talking about who's at blame for malpractice, because it ain't the student, right? Now we can trace that even further back. Why are we doing this? When you start to think about it a little harder, we run the risk of thinking that just because we have big data that can do all kinds of interesting things, that we can then start pointing to say, my program's better than your program. And now all we've done is we've created another hierarchy, another scale that we're all going to try to, we're going to get gamed. But, and so it's not useful. But the thing that really, really bothers me is this idea that it's an important question to know what happens in a context wherein you have lost all sense of control of the things that could be influencing a patient outcome. Did the nurse have breakfast that you're working with? Did the patient adhere to medication? Did the patient understand that the 2 white pills were different? Did the system enable you to do what you knew what would be the best income and intervention? Or did you have a grand total of 7 minutes with this patient? And now we're going to look back and say, well, that's because your institution didn't teach you PBL in the right way. This is a conversation that is a complete non-starter. There is ample evidence. There is ample commentary from people who are way more learned than me. And yet we continue to have this conversation. This paper is going to be another nail in that coffin, but for somebody, it's going to be another clarion call that they're going to be like, yeah, so they haven't done the study right yet. And I'm sorry, I have a lot of respect for everybody in our field who does scholarly work on all the topics. But this one is one of those topics where I find myself saying, why? Why are we doing this? Because quite frankly, if you continue to chase the line of reasoning to the end, ask why. This is dangerous work.
So you have feelings there, Lara, I'm hearing.
No, not one. I'm completely agnostic.
We're not doing a video. We're not
That was
doing a
pretty
video
neutral.
cast. We're not doing a video cast this week. But Lara, if you here's the play-by-play for those who are just listening to the audio. It was a scene out of A Few Good Men. Lara is channeling her inner Jack Nicholson. And
You can't handle.
All right, Jason. Lara's buckled up. I hope. The rest of us know this is a thing. Where do you lie?
So I appreciate Lara's very neutral opinion. So I have two major points. The first is, it is a legit question to ask of health professions education to ask us about accountability. So I would dispute that there's a lot invested in health professions education as a fraction of healthcare spending. It is probably one of the smallest investments of any industry in training as a fraction, as a percentage. I would love to have 0.1% of US healthcare spending put in HPE. That would be amazing. So it's legit to ask us for accountability. I also agree that brains don't equal kidneys. So the kinds of positivist studies designs that we have across clinical medicine, where an organ performs in a predictable way, doesn't apply to brains and social settings. And so the positivist paradigm is probably a wrong set of tools for the kinds of things that they're trying to get at. I agree with Lara's point that this is a flawed line of positive inquiry. I do have the same worries about why are these studies being done. It's okay to ask about accountability, but let's clarify what are the right questions and what are the right methods to get at those questions. I do want to finish with John set up this body of literature. This body of literature has a very consistent positivist approach to connecting med-ed outcomes to education. A lot of it has to do with standardized testing like exams. So there's a whole series of papers by Norsini. They're very elaborate papers. They do seek rigor, but they in order to do so, though, they narrow down using a set of assumptions that are not necessarily conducive to the fundamental question at hand. There's lots of reasons why people do well on tests, and not all of them are because of competence. There are lots of reasons why patients have plus or minus outcomes, and not all of them have to do with education. But it's no question in my mind that education is a factor to competence.
So if I was going to kind of build a false dichotomization of where we're at, part of the things I've heard from the three of you is these are questions that a whole bunch of people outside of the HPE world are asking. And so we need to be knowledgeable about that. The other side of the coin is the question and the potential solution is a non sequitur because of all of the false assumptions that underlie it. Let's jump into the paper. I'm going to quote the purpose from the authors: to examine the association between a physician's milestone ratings and examination scores with hospital outcomes for their patients. If you're going to read the primary paper, it's a big piece on the methods part, and I can see eyes glazing over already as we're moving to that section. So I'm going to try to chunk it as briefly as we can, but I'm happy to dive in. And I brought my little on-screen stats formula generator, so I can do some epsilon, and I'll put a sigma in there, and it'll be awesome. And already I see Lara pretending that she's having a seizure. So we won't do that, but unless necessary. So here's what they did. This is a retrospective, pause for effect, cross-sectional database analysis of a United States cohort. They took third-year internal medicine residents who finished training and did not go on for any further specialty or fellowship type training between 2016 and 2018, who cared for a patient within 3 days of the patient's admission, cared for them as a hospitalist Linda, apologies to you and your internal medicine colleagues, but essentially a hospitalist would be the primary generalist provider for an admitted adult patient without a subspecialty designation or a subspecialty or a specialty type of approach. So they're providing comprehensive care while in hospital rather than saying, I'm going to be the attending respirologist, nephrologist, cardiologist, etc. They looked at Medicare patients, so patients whose care is funded by government, who were more than 65 years old, who were admitted for a non-palliation, non-elective, meaning they came to hospital for acute care and admission, hospitalized between 2017 and 19, so there was a year for people to graduate and start practice. For 25 common diagnoses, you can see them all, sepsis, heart failure, etc., in moderate to larger hospitals. So hospitals that had more than 100 beds, meaning this was not the backcountry clinic that saw one case of COPD per decade. So these are centers where they're seeing regular type of medicine, probably typical of where you live and practice. They did a multivariate regression analysis that looked at the primary clinical outcome of either dead or readmitted at 1 week. These are patient-oriented outcomes that are pretty easy to measure. And then I'm going to just flag it because you're going to see some of my bias seeping in. They did a mean milestone rating of all of the 22 subcompetencies across 6 categories. So if you're not familiar with the milestone system in the US, there is patient care, medical knowledge, practice-based learning and improvement, systems-based practice, interpersonal and communication skills, and professionalism. And so you get a summative score on 22 items categorized across those 6 domains, but they pushed it all together and gave you a single mean score at the time of graduation. And then they did some categorization because we see a lot of range restriction with milestones data. And they said on this 1 to 9 scale, where 9 is excellent, 1 is incompetent, or discompetent is probably a better language. If you got a 7 or lower, that was a low score. An 8 or higher, that was a high score. And so if you were a 7 or an 8, you were in the middle. So they really only had a 3-point scale of everything they pushed together. And then their other measure was how you did on test scores for national certification exams on the first attempt, and they rated you by quartile. So they put you in the bottom 2 middles and the upper quartile. That's the results. That was a lot of language. There was a whole bunch of stats. There's a bunch of supplementary material. You're all welcome. What say you, Linda, Lava, Jason?
So a couple of things. I think they really tried to get a population of learners or practitioners that was relatively homogeneous with their inclusion and exclusion factors are. But so that was great. And then they lumped together various scores. So if I understood correctly, you could do extremely well on, professionalism and practice-based learning or something like that, and do terribly on communication skills, but it was still a mean of those scores, if I'm correct, John. Seems like an odd way of trying to get the scores together. The second thing is they chose the person who was quote unquote most responsible. But as I said earlier, there's a whole system in place. These individuals as hospitalists, the way I understand it, we don't have them in our setting, is that in general, they work shifts, so not everything that happens to the patient is going to happen when these individuals were around. So that's a bit of a problem. And the third thing is, I think they had to compare the knowledge part of the milestone with the exam level of knowledge. And I suspect that there won't be a direct correlation there. So I think that there are some problems with this, even not knowing anything about statistics, which, as you know, I call sadistics.
So we had, dear listeners, we had a whole conversation before we started recording today about how if you didn't have anything significant to add, you would just say ditto. So I'm going to wave that flag here to say I don't have anything significant to add because this paper is so far out of my methodological wheelhouse of comfort that I don't think it's appropriate. I am going to ask for a clarification because at one point, one of the criteria is that readmission is part of their criteria. And my concern is that I didn't see anywhere in the manuscript, and I know it's a short manuscript, but did it have to be readmission for the same issue, or is it like, a lot of people have multimorbidity issues. So I always find that a little, I don't know what's going on.
A quick answer, it's readmission for any reason. It's a common healthcare quality metric that suggests that you discharged a patient too soon and didn't have appropriate management plan or supports in the community. But you're right, it gets confounded all the time. But if you do any kind of health quality metrics, this is a pretty standard measure. And everybody knows that it can confound sometimes.
So, again, I'm trying to be empathic with these authors because there may be a time in my future where we try and do a study like this. So how would you operationalize your inputs? So in this case, they said our primary outcome measure here is this composite outcome that is very standard in literature, and it's patient-centered. So fine. And then another input is this exam variable. Now, do exams measure competence? Is in a whole other conversation that I think is relevant to this paper. And then the milestones, do they measure the same thing as the exam? Are they also a competence measure? I think the milestones have been looked at quite a bit at this point by the time this paper came out. I don't know how many papers, John, would you say, like 7, 8, 9, trying to correlate milestones with various things. So far, only one of them is positive with patient outcomes. It's the vascular surgery paper. And every other attempt, it's been like this. There's no correlation, or it's an inverse correlation or something bizarre like that. A lot of those papers have treated the milestones trichotomously, like this paper. So they torture a milestone scale if you assume it performs like a scale. And because of rate or range restriction, they say, oh, it's high or low, or it's satisfactory or not. And then they do their various stats. Milestones are a synthetic measure of workplace-based assessments and a learner's progress. So I've been thinking about this for a while, and I'm not really sure whether or not that's a fair assessment with patient-level outcomes, let alone the whole argument of the links in the chain between an educational monitoring tool and a patient-level outcome. So this paper has lots of flaws by their design, but I'm sympathetic to the authors. We put out a curriculum framework and an assessment framework, and now they're asking questions about it and how it relates to patient outcomes. I think it's a legit question. I'm just not sure that anybody should read much into this.
I just want to amend my description of the methods by saying they did lots of sensitivity analysis, lots of secondary analysis. They didn't account for it from a statistical point of view for chance, but it doesn't matter because all of those subsequent analyses, again, showed nothing of significance. But they really do try to give the best chance to show an effect of the independent variable, which is your milestone rating or your exam score. The critique, I guess, that we're going to hear in a second is lumping all of those milestones together as a predictor of future performance is maybe a flawed critique. But putting that aside, they try to make sure that with all the other clinical and patient-oriented outcomes, can they see it? So there's a ton of stuff here. Now, let's move to the results. They had 7,000 practicing hospitalists caring for more than 450,000 patients in nearly 2,000 hospitals. So this is not just a snapshot. I think this is probably state-of-the-art in that time frame for what was happening in general medicine wards across the U.S. 25% of admissions were by a physician in the low competency category, 8% in high, and 90% of admissions were by a physician who passed the knowledge exam on the first attempt. And so that's what you're going to see in terms of how these assessments of educational practice, how they kind of shake out. Here's the punchline. There was no association between the top versus bottom competency ratings overall, or even for the medical knowledge competencies when they looked at your milestones rating for that, on any hospital outcome measure. And I've included in our abstract, which you can find at paperspodcast.com, the two figures. They don't need to do any statistical correction because they see nothing significant there. The finding they do have that is of significance is they see that top knowledge examination scored quartile. So if you were in the top 25% on your national certification knowledge exam, you had an 8% reduction in 7-day mortality and a 9% reduction in readmission when compared to those who did the worst on the knowledge exam. And when they looked at everything else, they didn't see anything come out. Jason, Lara, Linda, what do you think of these results? What are these telling to us as educators who are directly or indirectly involved in the design and the delivery of our postgraduate or graduate residency education programs, depending what name you use, where you are in the world?
I don't know what to do with these results. The whole body of literature with these correlations, eating rice correlates with lots of things. It doesn't necessarily mean I should be doing correlations with eating rice. So I'm just really not sure what to do with this. The exam thing, standardized testing consistently has been shown to be associated with performance. That's one thing. The milestones thing, not sure.
So I'm going to echo your sentiment, Jason, in the sense that I have no idea what to do with this either, because quite frankly, I am so of the opinion that we need to be thinking about assessing our learners, absolutely, ensuring accountability, absolutely, but we have to do it in a way that's commensurate with what it is we do and the complexity of the context in which people work. At best, what we can do, in my opinion, is talk about their level of competency in the clinics where they trained when they come out. And then we do everything we can in the CME space to bolster, support, and enable. But these kinds of data, I honestly think it's a red herring. We're looking left when the real impact and the real things that we should be thinking and worrying about in terms of accountability, it's to the left. Oh, wait, right? What did I say the first time? Right. Thank you.
I agree with both of you. I guess the only thing I would say briefly is correlation does not equal causality. I think that's what Jason was trying to say in his long-winded way.
So here's what I think we need to do with the methods. I think, and the reason I brought this paper to the podcast is we need to know this, and we need to have a counterpoint to the people that are reading this. There are many clinicians who don't understand the health professions education literature, the rationale and the argument that each of us have made in different ways, who will say this and come back with so we should just go back to the old way then and save money. And we need to deconstruct the findings here and say, here's where they're problematic. And so here's a couple of the deconstructions that I might suggest that we think about. At least in Canada, the introduction of competency-based education came on the heels of societal dissatisfaction with our current education streams, which are modeled largely on, you have a period of time and our only test of competence will be a high stakes knowledge test at the very end. And there's dissatisfaction. And when we talk to the common insurer for physicians for medical malpractice, the number one issue in medical malpractice is around communications, which is never captured and never measured in any way when you have a knowledge exam. And so what we have then is the introduction of a program of assessment that captures authentic performance in many different ways. But when you pool programs of assessment into a single number, you lose all ability to differentiate. And more importantly, your variance becomes so massive that you lose all signal. It becomes all noise. And so it's bad educational and bad assessment practice to try to pool all of these 22 measures and say they all relate one to another when they are actually measuring very different constructs. That's a really flawed assumption. I think that's the Achilles heel of the design here. And then finally, our programs of assessment in competency-based training programs are to provide a formative and a roadmap forward. Remember that these are the assessments that happen at the end of training. Thank God that all the people that graduated from programs were at the level of a 7 almost at a minimum. I don't think there's very few that are underneath that. I didn't see the raw data, but it implies that the vast majority are at the level of a 7 or higher at the time of completion of training, meaning they are achieving competence ready for independent practice. It would be really problematic if we had assessment that said not ready for practice. And so if you have an assessment system that says ready for practice, and now we're going to measure how you practice, but everybody's the same, then you don't actually have an independent variable. maybe have a tiny little bit of skew of how ready we think you are for practice. But what we're trying to say is you've achieved competence. You're now ready for practice. Move forward into the training environment. And so the alignment of the purpose of these programs of assessment are not to say, hey, we want to become the gatekeeper for entry into practice, but we want to become the determination that you actually have achieved where we need to be. And the way, without getting into all the fine details about how milestones are actually captured in the US, which are not common across all competency-based systems, are such that they're adjudicated post hoc at the end of a training period, saying, okay, this is where we think you are. And presumably at the end of training, we're graduating you forward. We want to see residents are fit for practice. And so I think what we're seeing here is a type of analysis that is super confounded by noise, and where we see signal, it's probably a type 1 error. And where we don't see signal, it's probably truth and not a type 2 error. That's my hot take. All right, let me end with the conclusions from the authors who say, and this is how they frame it. So you have to be thoughtful about how you perhaps want to reframe it for the larger audience. More people are reading Jama than they're reading Teaching and Learning in Medicine, which is not a critique of teaching and learning in medicine. It's just a critique of who are we talking to? Are we having broader conversations? It gets framed this way by the authors. Among newly trained hospitalists, certification exam scores, but not residency milestone ratings, was associated with improved outcomes among hospitalized Medicare beneficiaries. Here's the so what. Suggesting that formally incorporating standardized examinations into residency ratings might improve their validity. That's their conclusion. My little bit of editorialization is knowledge exam scores still need and still have a role to play in our residency assessment systems, but on their own, they're insufficient. And so we should not return to the bad old days where we said a simple high stakes multiple choice exam question was sufficient to let you look after and manage the cancer in me or my family members. All right, let's move to our rounds of votes on methods. Varpio, I will insist and freak out if you come up with a none of the above, not answering. On a scale of 1 to 5, Linda, Jason, Lara, what do you think of the methods for this paper?
You know, I have to claim a bit of ignorance about the methods. I assume, as is in Jama, that somebody who knows about this type of investigation vetted it. So it's got to be at least okay. So I'll give it a 3. I do have concerns about selection and some other things that I've mentioned beforehand, but it's a 3.
I struggle with this. These are very rigorous methods with the wrong questions, so I'm going to give it a 3.
I'm totally going to abstain. I've got no right having a judgment on this. And more than that, I have to abstain because I want to watch you freak out. This should be fun.
I'm so glad we're not doing the video cast. At this point, I Hulkicize my shirt or something like that.
Yeah.
And then you realize I have nothing in common with the Hulk or anyone with muscles. I'm going to give it a 3. Their statistical measures of trying to balance the outcomes of patients is impeccable. This is classic big data or big database type of retrospective inquiries. I think they do a really good job there. They try to interrogate very subtly the educational assessments. They do a sub-analysis for the medical expert milestone rating, but they don't look at any of the others. And so they don't spend the equal amount of time on the other side of the house, which suggests to me that this author team might have benefited from a true educational scientist being part of that research team to say, hey, this is what it looks like, rather than saying, okay, we have these measures. Let's use these measures in the same way that we use 7-day readmission with all the confounders. But we understand 7-day readmission to be nuanced in this way. So this is how we're going to adjust for it, et cetera. We're going to look at 30-day readmission, et cetera, et cetera. And they don't do the same on the educational side of the house. So perhaps not as well informed in the nuance of what happens. For that reason, a 3 for me. Reverse order in terms of educational impact. And here, anything that says 0 impact, be thoughtful about which audience you're thinking about, because a lot of people are reading this. Lara, Linda, Jason.
I'm stuck in terms of what impact number to give it, because I want to give it a really low impact number, because I really don't want this to be the marker against which we think about what's quality, skills, success our learners have or our institutions have. At the same time, I recognize I want to give it an impact number that says we really need someone to develop the nuanced thinking of a good counter argument. Because right now, me saying this is not the right argument, we need to be more nuanced. Our argument has to align with it needs to be commensurate with the things that education can and should and must be doing. It's really nice for me to stand on my high horse and say that and not have the right counter argument. So maybe it's a 3 because I'm feeling like we need to work on that. And maybe this is impetus for me to say that maybe I have to.
Can I just say, you actually gave us a categorical number, a categorical score.
Yeah, it was totally an
without
accident.
A sparkle pony or sheepadoodle or whatever the heck you've been doing previously. So this is a win for me. This is the beauty of my favorite podcast episode so far.
There you go. Merry Christmas.
So I'm torn with this because for this audience, I think this audience needs an interpretation. I'm not aware, I didn't go back and look and see whether there was an editorial in Jama that went along with this. I'm assuming there isn't. But we do need to have some sort of an opinion piece as a counterpoint. And then, of course, we need to figure out a way to have studies that aren't just this type of study. I'll give it a 3.
Okay, you know what? I'm going to give this a 4. Here's why. I have the same concerns about how dangerous this paper is and about how it's asking the wrong questions, but it's going to be highly discussed and highly cited. So we have to address it. I'm giving a talk in 2 days. It's related to this topic. I'm going to totally bring up this paper. It's going to be on a slide. So this is a 4 for impact, but that doesn't mean I agree with it or that I think it's right or that I think it's the right approach. It's just important that we have these accountability papers and that we address our concerns with them.
And I think, by the way, that we can't just give it a low number because we don't like it or don't agree.
Yeah.
All right. I'm going to give it a 4, heeding Linda's advice. Everybody's going to be talking about this outside of your education world. I think we need to encourage our community to know what this paper means, know a counterfactual to the punchline, and be able to beat interpretations and then policy decisions to a decision, meaning let's not let the summary in the discussion guide where we might move our assessment systems moving forward. I also like it that it makes a small argument that there's still a place for knowledge exams. I still believe that. In isolation from all other types of assessments and as a replacement for a program of assessment, heck no. But we still have a place for knowledge exams, and we do see some kind of marker happening here in this data. So
agree.
With that, you've heard a very controversial topic. You can loosen your seatbelts, maybe roll down the windows in your car if you're commuting and let a bit of cool air in if you've been getting fired up as you've listened to this debate. We'd love to hear from you. You can reach us at our email address, which is thepaperspodcast@gmail.com. You can find the show notes and also leave a comment for us on our website, which is paperspodcast.com. Thanks so much for listening.
Talk to you later.
Bye-bye.
Take care, everybody. You've been listening to the Papers Podcast. We hope we made you just slightly smarter. The podcast is a production of the Unit for Teaching and Learning at the Karolinska Institutet. The executive producer today was my friend Teresa Sörö. The technical producer today was Samuel Lundberg. You can learn more about the Papers Podcast and contact us at www.thepaperspodcast.com. Thank you for listening, everybody, and thank you for all you do. Take care.